Hello, and thank you very much for the opportunity to talk about fatigue in systemic lupus. We are the Lupus Day or the Lupus Week, and it's actually a great honor to give this talk for Gladel. So these are my disclosures. If you do not follow me already on Twitter, you know what to do. And I'd just like to start with a little dialogue. A doctor talking to a patient with lupus. My dear madam, I have excellent news. You are absolutely fine. No, doctor, I am not fine. I have fatigue. And we all know that when you've been stuck in this situation, it's really going to be difficult to move forward. So what is fatigue? Well, there's something a little bit paradoxical, is that everybody from the general population has some experience of fatigue. We have all experienced fatigue, but it's really difficult to find a consensual definition for fatigue. Usually it's seen as a combination of physical and or mental weariness. But I have to say that in the context of autoimmune diseases, it is usually not due to an excess energy expenditure. And also it is usually not improved by rest. At least this is what is most commonly reported by the patients. It's very commonly multifactorial. It can be lifestyle factors, it can be the stress, it can be the role of medication, overwork, and of course, mental, physical illness or disease such as systemic lupus. So fatigue is the most common patient-reported symptom in the context of SLE. Is this true or is this false? Well, we know it's true indeed. This is a very large survey, more than 4,000 participants across 35 European countries. And you can see that unfortunately, fatigue has been voted as the most common and most bothering manifestation of systemic lupus, in front of all other manifestations, including joint pain. When you survey social media, such as Twitter, fatigue is also very commonly reported on social media. So we've been really interested in this problem of improving fatigue in lupus for several years. And we started with the first study, which was focused on the predictors of fatigue and severe fatigue in lupus. So we analyzed the cohorts of lupus patients we were following, and as you can see, only 1/3 of lupus patients do not have significant fatigue using validated scales. For 2/3 of patients, there is significant fatigue, and for 1/3 of patients, this is major fatigue. So that's obviously a very common and a very difficult medical situation to manage. And when we debrief the patient about the way they live with fatigue, we know that there's a very strong impact on the quality of life. So I'd like to share a small case, a little case, quick case. Marie, 52 years old, she's a patient with lupus. She's a nurse working in rheumatology. She's been diagnosed with lupus about 10 years ago. But for 6 months, she has increasing fatigue and no other complaints. And the clinical examination is completely unremarkable. So how do you manage this case? Well, together with some colleagues, we've been thinking about that, and we've been writing a paper which is really dedicated to practical management of fatigue in SLE. You can screen the QR code and you will get the paper imported in your mobile phone for free. I think the first step is really to assess fatigue using calibrated scales, validated PROs, can be for seat fatigue, MFI, FSS, whatever you want. But I think it's great to measure fatigue in a calibrated way. And I already know what you're going to tell me. We don't have the time to do that during consultation. But what I would like to tell you is that I guess the patient is waiting for a little bit in the waiting room. And maybe this is the proper spot to try to measure fatigue. And the reason why we want to measure fatigue is that we know that it is an individual experience. And so we need to standardize the measurement of fatigue to be able to compare fatigue intensity across individual, but also in time. So for that, I think EULA has done an amazing job with what is called the Outcome Measures Library. Again, you have the address, computer address, plus the QR code. If you go to this web page, you have most of the scales that are useful for rheumatologists in many, many languages. So you can download fatigue scales for free there. But I must say that when you try several fatigue scales, and this is taken from the LEAF study, you see that many of these scales are correlating quite well. Here you have more than 1,000 patients. They've been assessed using the seat fatigue, the MFI, and the VAS, just 0 to 10. And you see that the correlation is actually quite good. Of course, the seat fatigue and MFI are well more defined, but if you have no other opportunity in your daily practice, 0 to 10 VAS is already something great. The second step when you've measured fatigue is to rule out common medical cause. There are many of these, I would say, routine medical causes. The number one is anemia, which is, of course, quite common, whatever is the reason in the context of lupus. Who has never been dropped by a case of fatigue? And in the end, it's simply anemia, profound anemia. But there are other reasons for fatigue, dyscalcemia, organ failures, of course, slow adrenal failure in patients who have stopped corticosteroids during the last 6 months. It's very commonly manifesting as fatigue. Thyroid problems, sleep apnea. It's so common that our patients gain a lot of weight because of corticosteroids. So I think little questions, to check, screen for sleep apnea is the minimum that should be done. And of course, there are some specific complications due to the chronic stimulation of the immune system, B cells, such as lymphoma, that we should at least rule out by doing a clinical examination and a little bit of a standard checkup. Then I think the true question is lupus active, yes or no? When we performed our study, we found a significant association between disease activity and fatigue. You see that the odd ratio is not very high, 1.05, but this is for each single SLEDAI point. So when you have a SLEDAI of 10, it multiplies by 10. So it's, of course, a lot more. And it's true that when we cluster our patients with lupus in kind of fatigue, we find different profiles for fatigue. One of these profile is the patients who have low disease activity and they have low, moderate fatigue. And on the other side of the spectrum, of course, it's a minority of patients, but they have high disease activity and high fatigue. This is really what I'm telling, correlation between disease activity and fatigue. And we have reasons to understand why it's like that. It is the role of interferons. We know interferon alpha is very, very important in the context of lupus. But we know that when we have a viral infection, we are producing huge amount of interferon alpha. And we all know that fatigue is a very strong defining feature of viral infections. So when lupus is active, obviously the best way to control fatigue is to control disease activity. And although we have evidence for randomized controlled trials for a few treatments, anifrolumab, belimumab, and so on, my guess is that most treatments who are able to control disease activity will be able to control fatigue due to disease activity. We do not need randomized controlled trials with everything. Of course, a strong believer in evidence-based medicine, but we cannot do evidence-based medicine with everything. There are other options, such as N-acetylcysteine, which has been proven to improve fatigue, but you need very high doses, and at these doses, it's poorly tolerated. And of course, all our patients have a deficiency in vitamin D, and it's always great to correct for that. And there are a few data showing that it may help improving fatigue. So why not as part of fatigue management? We will do it anyway. But what is really striking to me is that when you follow trajectories of disease activity and fatigue in time, they have distinct trajectories. And the trajectories with the higher fatigue are not associated with disease activity. They are associated with fibromyalgia. So when we fail to diagnose active lupus in our patients, that could be an explanation for fatigue. I think we need to search for something else. Is there chronic pain? Is there anxiety, depression, or truly fibromyalgia? And as I've said before, strong association between fatigue and fibromyalgia. And this is largely mediated by pain. You see that pain, whatever is the reason, it can be chronic unexplained pain or pain due to active disease, whatever, there is a very strong correlation with fatigue. So that's an important question. Do you have pain? It's also strongly associated with sleep issues in SLE. So this needs to be treated, corrected properly. And as I said before, fibromyalgia is a very common association in the context of lupus. When we screened for fibromyalgia using the first score in LEAF, we found that almost 60% of patients who participated to LEAF screened positive for fibromyalgia. Of course, this is strongly intricated with psychological determinants, especially anxiety, depression, and stress. And you can see that the odds ratio for these anxiety, depression is very high in association with fatigue. So this is something we need to assess. Not always easy, of course, but anxiety, threat, depression, anxiety, stress are strongly associated with the way the patients perceive their disease and with fatigue. And I think it brings us to this cluster number 2 of patients, which I have not talked about yet. You can see 25% of patients had low or no disease activity, but they had very high fatigue, very high anxiety, and a high depression score. And we already know that this cluster 2 is the group for which it's the most difficult to find good options, because we are not going to increase the treatments for disease activity, as this is not going to solve the problem. So what can we do? Well, we need to go for targeted intervention, and I really think that the minimum is physical activity. It is proven across several randomized controlled trials that physical activity improves fatigue in the context of SLE. So we really need to be convinced and start, and it's always the same problem. We have to start little by little, because a huge majority of lupus patients do not meet international recommendations for physical activity. We already know that because of pain, because of fatigue. But it's really interesting to know that when you perform disease activity, there is significant improvement in fatigue, there is significant improvement in depression, there is, of course, improvement in the aerobic capacity, and there is no worsening of disease activity. This is very important to explain to our patients. So one way to implement that is to have a look at these recommendations, EULA recommendations for the non-pharmacological management of SLE. And you are probably aware that we have just published some specific recommendations for physical activity and exercise in persons living with SLE. This is the consensus for an international task force. And again, if you screen the QR code, these recommendations, they are imported in your telephone in a very direct manner. So you can just follow what is explained in this. Something I'm a strong believer into is patient education based on websites, web apps. I really think this is the future of patient education, to be able to give good advice based on validated apps. And truly, this is, I believe, the future of fatigue management. We have developed a tool called LEAF, the Lupus Expert System for the Assessment of Fatigue, which has been used by more than 2,500 lupus patients. It doesn't solve the problem of fatigue, but it provides personalized feedback to improve fatigue. And you have a QR code right there if you want to try it for yourself. We assessed huge cohorts of patients. You see that almost 80% of them had significant fatigue. Fatigue was across all the domains of fatigue: general fatigue, physical fatigue, mental fatigue. And it was really interesting to see that a significant proportion of patients reported pain, high stress, high screening for fibromyalgia, but also what we've been discussing before, insomnia, anxiety, depression, clinically defined, are actually very common in this population, and we really need to tackle this issue. So just to conclude, you know that fatigue is very prevalent in SLE. It is strongly multifactorial. There is a role of common disease, anemia, thyroid problems, but also disease activity and damage. And when we are not finding anything very relevant, no active disease, well, we should open the door of chronic pain, anxiety, depression, problems, sleeping, trying to solve these problems bit by bit, especially through physical activity. So I think this targeted intervention, starting physical activity very slow, just 5 to 15 minutes for the first day, for the first week, and then you increase bit by bit, trying to reach 20 minutes, trying to reach 30 minutes, bit by bit. This is the best option for fatigue. With this, I thank you very much. Muchas gracias.